So I was asked to cover this topic, and unfortunately we have to say immediately that we don't have long-term follow-up on this technique of guided surgery, because it's a quite new procedure in the field. But we can only trust the few papers appeared from 2008 to 2014 and to trust the clinical experience of all the groups and the schools that have been working on this topic. When dental implantology came on the stage, and it was almost 30 years ago, one of the words accompanying all the projects and the dreams of the researchers was simplification. How to make this treatment simple. And theoretically, the treatment should be simple either for the clinician or for the patients. But unfortunately, most of the time, we only are able to make the patient's life easier, but not our one. And so in the 80s, we started working with regular implantation, and when the bony support and the soft tissues are very well represented, it's quite easy to build up a full arch reconstruction and to give the patient a good medium or long-term result on implants. And we heard from the previous lecturer how the maintenance therapy is important to guarantee the long-term result of the implant therapy. Then, after being confident with implant therapy, we started to think of simplifying and to giving chances to the patient to have a quicker treatment, a low morbidity treatment. And so we started thinking about immediate loading. While waiting for a long time for osseointegration, there were scientific evidences of the capability of the implants to bear a loading even immediately after their placement. And so we started, and we, at that time, were doing extractions, implant placement, impression for the temporary prosthesis, and 24 hours later to deliver a patient a temporary prosthesis, which was transformed in a definitive prosthesis 3 to 4 months after the treatment. And of course, even this procedure showed to be very reliable. And again, for the patient, it's much easier. It's not really easier for the clinician. The idea of implant extraction and implant of the tooth extraction and implant placement is quite important in the aesthetic area. So we started to try this procedure even in the aesthetic areas where we have tricky points like the stability of the soft tissues or the buccal plate. And we now, after 20 years, we know that there are some criticisms about the enthusiasm of a few years ago about the stability of the long-term success, stability of the soft tissues, especially in the aesthetic area. By the way, in order to simplify the life of the patients, we started to work with this kind of procedure, so taking out very gently the tooth, placing the implants at the same time, giving the provisional, very often using the acrylic tooth for the surgical stent, taking impression at the same time of implant placement. And you know, it's not easy for the clinician. It's much easier for the patient, now that after 2 hours he's going out from the office with a new tooth, even provisional. And after a few months, we can finalize the result and giving the patient full ceramic or gold ceramic rehabilitation, using all the tricks to guarantee success, platform switching, and so on. And this is the situation 9 years after the treatment, and you see that we have a good stability. Unfortunately, not always we are able to achieve this kind of result, but you know that in the congresses we are usually showing our best cases. No? The problem is going to be bigger when we are dealing with major atrophies, when the bony support or the soft tissue support is not adequate. And even in those cases, we have been working with, and we are working with major surgeries in order to build up bone, like in the classes 5 or 6 according to the health. And you know that this kind of treatment don't provide really for simplification, because it's a long treatment. We need the bone augmentation. We have to wait for a few months to place implants. Patient is not allowed to wear any kind of prosthesis if he's a totally edentulous patient. And this kind of procedure usually provides for the use of iliac rest or calvaria bone rest in order to build up horizontally or vertically the bone, and after 3 months we can remove the fixation screws, place implants, and then to go on with the final rehabilitation, which can combine aesthetics and function for the patient. That's the outcome of the treatment, and that's the situation after 7 years, how the patient looks after 7 years. And this is the X-ray control. Even in these cases, we have been dealing with the word simplification, and so in order to make the patient's life easier, again, we are simplifying the life of the patient, but not for the clinician. We started a few years ago to use homologous bone blocks instead of using iliac bone, autogenous iliac bone. This is a case like the previous one. You see the patient already had implants in another office a few years before. This is the remnants of the surgery, but it was impossible to go to look for that burr inside the soft tissues. And the problem is how to build up bone in the upper jaw. So again, you see the class 3 appearance of the patient, and you see here the iliac homologous bone block that is modeled and adapted to the recipient side in order to augment vertically and horizontally the maxilla. And after 7 to 8 months, we can take out the screws, place the implants again, and after 3 months, to make the soft tissue augmentation to recreate the keratinized gingiva around the implants, and go on with the final rehabilitation. And that's the final outcome of the case and the aesthetic result. So, we have been talking about simplification, and we are in an era in which we try to simplify, but simplify is very often synonymous of microsurgery. In all the disciplines, surgeons are working and trying to reduce the surgical approach to lower the morbidity for the patient, and so the idea of creating minimally invasive surgeries is affecting also dentistry. And which are the situations more favorable for this kind of treatments? Of course, senior patients with reduced jawbone support, patients suffering from systemic diseases who are not suitable for major surgeries, phobic patients, again, or patients with, very active social life, so patients not liable to stay with them for a long time without teeth. And this kind of approach can be a solution on condition condition that we have enough bony support. And so guided surgery was born with this idea, to make surgery easier, particularly for the patient, by guiding the implant placement with a computer program. So we started early in the 2000 with the navigation systems. I remember Rolf Evers, who was one of the initiators of this technique. Then we moved to a template-based due to the deviations from the virtual to the real that we had with the navigation systems. And the treatment is simplified, again, for the patient, but it's not simplified for the clinician, because the pre-operative planning is sophisticated, it's complicated, and even surgically, this is not a surgery for a junior level surgery, because we will see from the literature that the deviations from virtual to real are still present, and we have to calculate them when we are planning the implant placement virtually. So the treatment provides for a pre-operative planning with the radiological stent. The patient is sent with this radiological stent to have a CBCT. Then from the CBCT we are preparing the implant placement, virtual implant placement. The lab is preparing, according to our planning, a surgical stent, and then we have the surgery that actually we should remind that it's a half-blind surgery. And as always, all the blind surgery, there is always a certain amount of risks we have to evaluate. So let's see this case. This patient came to my office with these periodontal problems. We were able to maintain the teeth in the lower jaw with the maintenance therapy, but we have to take out all the teeth in the upper jaw. And the only wish from the patient was to try to maintain this implant, which was actually a little bit buccal, but well also integrated. And so we did plan virtually the situation. You see the CT before and after the extraction. On this CT scan, we are preparing the virtual planning, taking in account also the soft tissues and the prosto in order to calculate precisely the emergence of the future abutment. You see part of the planning, and we can have the bone profile, the soft tissue, and the prosto, so we can easily place the implants virtually in the right position. And of course, when we are at the moment of surgery, after fixing the surgical stent very firmly, we can, with a very low morbidity, with a very low trauma, install the implants and giving the patient immediately a prosthesis, which is transported the final one after 3 months. And this is the healing of the tissues, and that's the final restoration and the final outcome of the treatment. The patient is a colic with a terrible vomit reflex and a type 2 diabetes. So these kind of surgeries are quite very well indicated when patients have this kind of problems. This is another case, a double jaw, a dentalist patient. Again, we can prepare virtually the planning, the soft tissues. Having this kind of reproduction in the software is very important because we want to have the abutment emerging surrounded by keratinized tissue. If we don't have, we should prepare the soft tissues prior to implant placement because we know how important the presence of keratinized tissue around the implants is in order to prevent perimucositis and periimplantitis. And again, I go quick with procedure, we can have a 3D reconstruction to simulate the position of the implant and the fixation devices as well. The lower jaw, and these are the surgical stents with the silicone bites. We need to reproduce at the moment of the surgery the exact position of the surgical stent. Then the surgery is quite easy. You see the sleeves that we are placing the implants, and then the trauma after the surgery. The lower jaw, something we cannot foresee is the stability of implants. In this case, in fact, we had no more than 25 Newton stability in the upper jaw, so we decided not to load immediately the upper jaw, but to load only the lower jaw, and the upper jaw was loaded after 3 months. So you see the temporary lower jaw with the various abutments, and after 3 months the face ball for the registration of the dimension, the walks up, the aesthetic try-in, that's the superstructure, and this is the final outcome of the treatment. The aesthetic result, the X-ray control, and it's after 3 years. So what we have to say, are these procedures accurate or not? And the problem is more important when we have edentulous patients, because we don't have stop represented by natural teeth. When you have supported templates, like in this case, everything is easier, and we have less deviation from the virtual to the real than in the edentulous patient. But we can today do a digital planning to digitally build, manufacture the provisional, to have a digital articulator, and to digitally plan the implant positionment and placing. You see the stand, the provisional, how it's digitally with a 3D system prepared, manufactured, and the time of surgery, it's easy. Sometimes you have to go, by the way, with an open flap procedure when the bony envelope is very thin, or you think that you need to do a small filling of the buccal for aesthetic reason with bone substitutes. And then the procedure is quite easy. So about the accuracy, from the literature, we have to some information about the deviation axially, coronally, apically, and on the axis of the implant from virtual to real. And we have some studies. We did this one that is still running on today with Cameron implants, evaluating the deviation in millimeters for apically to coronally, and in angles for the axis deviations, by superimposing the CBCT of the virtual planning and the CBCT after the surgery. So we did 62 implants with the post-operative CBCT, and we did the volume extrapolation, and then we've been matching the two CBCT to evaluate the deviation of the two CBCT. And if we are going to see the paper working we have in the literature, and comparing with the one we did at the moment, you see that in our study with the system we are using now, we have about 50% less deviation from virtual to real, but still we have some deviation. So we have to take into consideration this part when we are planning, and a prudential approach has to be done from the clinician, just maintaining some distances in between implants and the vital structure like vessels, nerves, or sinus. Recently, a paper from a Brazilian group appeared on an Italian journal, and they did more or less the same study we did, but again with other implants and with another software system. You see that we have, by the way, a remarkable difference in between the virtual and the real. So that means that we are again simplifying the treatment for the patient, but for us is still not totally simple. As final remarks, what we could say that the pro are for the treatment of patients, of course, with adequate bone support to implants. If you don't have enough bone support, particularly in the dangerous patients, it's not an ideal procedure. It's wonderful for patients with contraindication to major surgeries, or patients with limited time availability. It's okay for patients with immediate aesthetic requests, so you don't want to stay without teeth for more than 12 hours. Or, of course, phobic patients. On the other hand, we still have to evaluate always the necessity to build up soft tissues, which are as important as the bony tissues around the implant. We have to evaluate as a first sight the patient, the opening degree. If the patient is not opening too much, there is no space for all the devices to enter the mouth, particularly if the patient has natural teeth still remaining. We have to evaluate the financial sources. All these systems provide for an increase of the costs for the patient. And we have to evaluate the accuracy of the different software. There are remarkable differences in the different softwares, particularly in terms of deviations, of course, particularly if the software doesn't take into consideration the registration of the soft tissues. And the components offered by the companies. Often we don't have adequate prosthetic components making our life easy. Sometimes it's easy to place implants, and then we take a long time to adapt the abutments, and so the company had to push and try to really create a simplified procedure, not always for the patient, but even for the clinician. And of course, the surgeon clinical experience is important. There are sometimes you have a very thin bone remaining, and you have to feel if the burr is preparing the implant site within the bony envelope. If you have a very thin bone and you have a deviation of 1 millimeter, it can make the difference. So it's not a procedure for young surgeons, as people can see, can believe. So if we think, if we agree with this sentence from Schopenhauer, they say that in every art simplicity is essential. I think that we have a lot of job to be done to simplify not only the patient's life, but even, and most important, the patient of the clinician. Thank you very much for your time.